cancer is a global health problem. It's increasing. However, what I see more and more is that it's a service and system issue. It's not just this drug works or this surgery is very good. It's can we make sure that it's delivered with the relevant quality, that it gets to people that need it, that it's affordable, that it can be implemented at scale. Those tend to be the major issues that result in the gaps in survival from what I see both in the UK and internationally. We know if you're diagnosed with a particular stage of cancer, and by the way there's sort of 220 cancer types as such, but even the commoner cancers such as head and neck cancer, lung cancer, prostate cancer, radiotherapy is a core component of the treatment in the curative phase. It's required in 50% of cases. When you're giving radiotherapy treatment, there's areas or the cancer that you want to treat. There's also areas that you want to avoid. So the two main components that are done after a CT scan is taken. One is contouring, which is to outline both where the tumour is and areas that are a high risk of tumour spread, but also areas that are at risk of radiation damage, which can take 2 or 3 hours. The planning, which is where a physicist would then work out where the radiation beam should go to maximise the dose to the cancer and minimise the dose to the normal tissues which are at risk of damage, can take half a day or a full day potentially. So ARCHERY aims to test the quality of artificial intelligence algorithms to do the contouring and the planning of radiotherapy treatments. So rather than potentially taking weeks in a normal workflow, depending on availability of staff, in minutes. So we chose the country sites of South Africa, India, Malaysia and Jordan, as these are middle income countries. These are countries that are facing an increasing burden of cancer. The demand for cancer care in India is outstripping supply in many respects, given projected increases, particularly from head and neck cancer, prostate cancer, for instance, breast cancer. The need for high quality radiotherapy, for reducing waiting lists and for cancer care to be affordable and equitable means that these AI solutions are going to be very much part of usual care.
This is what we would do. We would look at all the scans, the CT slices, and then if you see this is here is the tumor. So we would have this. So this we would contour manually. So that is where the advantage of what AI, that is what ARCHERY is trying to do, is trying to evaluate whether if we had an automated process to do this entire exercise and not compromise what is actually disease, can we save the time? Because when we do all these processes manually, we're actually noting down time. I'm a radiation oncologist by profession and my specialization area is head and neck cancers. So in the ARCHERY study, I am a co-investigator working out of the Tata Memorial Hospital, Mumbai. Today, my resident finishes work in the OPD, in the outpatients, and then goes and sits and contours each patient manually. So the 30 to 40 minutes that he spends on one patient, he can be spending it doing something else that's more productive. Either we can treat more patients or we can use that time to do something else related to work. One thing for sure will happen is that we will reduce the time spent by an oncologist essentially in trying to just plan a patient. We may be able to spend that much more time talking to patients, because just now if you see the crowds outside versus how many we have to treat.
In the next 20 years, it is going to be an epidemic of prostate cancer in countries like India. So it is important that the AI and studies like ARCHERY gets into the treatment process right from now, and I think it's a great time to begin this thing for prostate cancer. Prostate cancer is increasing rapidly in India, and our lifestyle is changing from what it traditionally was to what a Western diet and lifestyle is. Plus, we are living longer. So one of the greatest risk factors for prostate is a longer life. With prostate cancer, unlike some other cancers like head and neck or cervix, the experience of oncologists in places like India may not be adequate because they don't see enough yet. A physicist needs to have a whole lot of experience to be able to deliver a very high dose to the prostate, and sometimes they may not be able to achieve that. So some help from AI would really help.
I think one of the challenges with AI, it's ubiquitous and constantly seen as a solution to some of the hardest, most complex challenges, not just in the UK but internationally. Whilst I think AI has huge promise, it needs to be evaluated effectively, so because there's plenty of AI and technical solutions that end up in the cupboard, and it would be a shame for something that has so much promise for the same thing to happen. The trial is planned to report in the latter half of 2026. If it does meet its study endpoints, there is a commitment to offer the software not-for-profit for public sector hospitals in the low and middle income setting. And I think very much as we move forward in the future, there are many areas to look at, not just from a clinical perspective or a technology evaluation, but from a health system perspective, issues of inequalities, issues of financing, issues of building capacity. And I fully expect that within the infrastructure of LSHTM and partners more broadly, nationally and internationally, you can really achieve impact in cancer.